is often a challenge, and therefore that's something which we should know. So before we go to that, I'll thank Bansi for inviting me here, and as he has said that we should have something about history. So I have got 3 points here. Interesting to know that James Collip actually was the first person who gave the understanding about hypoglycemia once he started using insulin in 1922. In 1924, Seal Harris identified non-diabetic hypoglycemia. That's the first time he spoke about non-diabetic hypoglycemia, and he described that hypoglycemia can be, often mistaken for hysteria, brain tumor, coronary thrombosis, epilepsy, mental disorders, gallbladder stones. All these can be, the misdiagnosis that can happen for people presenting with hypoglycemia. So that's the diverse manifestation. So that gives a good sort of intro to my presentation. And then finally, I would also say that, much later in 1972, another interesting cause of hypoglycemia was detected. That is autoimmune hypoglycemia, autoantibodies to insulin. So that was described by Hirata, Japanese scientist. He described that in 1972. So these are some interesting historical aspects that I would like to go through. Wanted to present before my talk, which I'll discuss these different aspects in the presentation. So basically, glucose is an obligate fuel for the brain, and under physiological conditions, the brain always requires glucose. So glucose has to be very tightly regulated within a small range, and that is a challenge, and that is done by different mechanisms which come into play. Once the glucose level starts going below 80, the insulin secretion gets stopped. Then after that, what happens? There is increase in glucagon secretion once it goes to about 65 or so, and once it further goes down, then there is increase in epinephrine, increase in cortisol, increase in growth hormone, and finally, and around 65 or so, patients start getting the symptoms of hypoglycemia. That is the neurogenic symptom, neurogenic or adrenergic symptoms, because of the secretion of epinephrine, as we said just now. And then when it goes down further, then you have neurological dysfunction, that is neuroglycopenia. So there is compromised behavioral defense, and that leads to the neuroglycopenic symptoms. Sometimes there can be unawareness of hypoglycemia. What do you mean by unawareness? Is that the adrenergic symptoms are lost, and the patient directly presents with loss of consciousness or the neuroglycopenic symptoms, as we are saying. So these are the physiological responses. As you can see, a normal plasma glucose is generally in the range of above 70 is expected to be normal. And common presentation, as I mentioned here, is you have the adrenergic symptoms because of sympathetic overdrive, and then you have the neuroglycopenic because the brain has less of glucose being supplied, and you have all the symptoms that you see in the listed out in this figure. So how do you define the severity? ADA has actually given a definition for that. They said that level 1 hypoglycemia is between 54 to 70. So below 70 is hypoglycemia, 54 to 70 is level 1 hypoglycemia. Level 2 is when the blood glucose levels are less than 54, and level 3 is any degree of hypoglycemia, any severe hypoglycemia where patient requires assistance, cannot recover himself, then you call it as level 3 hypoglycemia. And then you have other conditions, like you have relative hypoglycemia. That is somebody who's used to a 300 blood glucose levels. Even if it comes down to 200, he may experience symptoms of hypoglycemia. So that's not real hypoglycemia, but that's a challenge when you're managing patients with severe hypoglycemia. If you're managing them, you may have this challenge. But important is who requires investigation is those who are fulfilling the Whipple's triad. That is, symptoms are there, and then there is relief of symptoms with plasma glucose is raised, and low plasma glucose is measured, and then it is relieved by correcting that. So that is when Whipple's triad is fulfilled. Then only you you do further evaluation. And classically, you can say, traditionally, you can call it as fasting hypoglycemia or post-absorptive and reactive hypoglycemia. And then there is another, clinically, you can classify patients who are looking very ill or medicated individuals. They have different set of causes for hypoglycemia, and then there are seemingly well people who are having hypoglycemia. There are different reasons for that. So I'll just quickly go through these two aspects. So if you look at seemingly well individuals, they are those who have endogenous hyperinsulinemia. They could be because of insulinomas, they could be because of these antibodies to insulin, all these conditions, post-gastric bypass hypoglycemia, and all these can be in individuals who are looking very well. And those who are on medications, like several medications, insulin is the commonest thing that we know of. But other medications like alcohol, then critical illness can lead to decreased glucose production, that is gluconeogenesis coming down, and hormone deficiencies like cortisol, epinephrine deficiency, glucagon deficiency, or there could be non-islet cell tumors which are producing factors which are causing hypoglycemia. So in the drugs which can cause hypoglycemia, commonly insulin secretagogues that we know, SUs are the most common ones. Alcohol is a common offending agent because alcohol causes reduction in the gluconeogenesis. So glycogen, and also glycogen depletion happens with alcohol. And the other drugs which have lower quality of evidence are listed out here. You could say that you have some of the quinolones which can cause hypoglycemia. Then you have ACE and then you have some evidence with chloroquine and lithium, and so such drugs can also cause hypoglycemia. So we should be aware of this. And renal disease, because of the renal clearance of insulin is reduced, and also because of decreased renal gluconeogenesis. And similarly, hepatic disease can cause hypoglycemia. Sepsis, because of there is increased cytokine mediated hypoglycemia happens there, and decreased responsiveness of the glucose counter regulatory mechanisms happens in sepsis. So these are situations where a person who's ill can have hypoglycemia. In addition to that, hormone deficiencies like cortisol deficiency, hypopituitarism can present with hypoglycemia, particularly in infants and young children. Then the non-islet cell tumors are common causes of hypoglycemia. These are rare epithelial or mesenchymal cell tumors, which are most commonest is hepatocellular carcinoma. So these are producing factors like they are IGF-2, which can have which can actually have insulin-like action and can cause hypoglycemia. Then so various types of tumors, even epithelial cell tumors and prostate tumors, adrenal tumors can cause hypoglycemia. So they produce a pro-IGF-2 which poorly binds to the insulin receptor and produces an insulin-like action, while endogenous insulin is suppressed. So you may have low insulin levels, high IGF-2 levels, which is generally not measured, but still hypoglycemia is there. So in a seemingly well individual, it is mostly because of endogenous hyperinsulinism, and the commonest causes are insulinoma, which is a tumor secreting from the pancreatic beta cells. Then you have nesidioblastosis, where there is no tumor but there is hyperplasia of the beta cells. And then you have non-insulinoma pancreatogenous hypoglycemia syndromes, which are again conditions where there is no tumor but there is excessive insulin being produced in the beta cells. And then post-gastric bypass and autoimmune hypoglycemias, which I just spoke about, those can also cause hypoglycemia. Insulinoma is a rare tumor. Incidence is 1 in 250,000. Less than 10% are malignant. Most of them are benign tumors. They can be associated with MEN1 syndromes, and they have a good survival after surgical removal. And the other category is nesidioblastosis. Then you have the NIAPHS, the post-gastric bypass, and autoimmune hypoglycemias, as I mentioned. I would just like to mention here that autoimmune hypoglycemia, which I was speaking about, Hirata describing this is often triggered in people who have got a susceptibility, that is HLA-DR4 such susceptible genes who have this. It is triggered in such people by viral infections like rubella, mumps, and measles, or it can be stimulated by, induced by even drugs like alpha lipoic acid, which is commonly used. Many of us may use it for treating diabetic neuropathy. That can actually trigger a autoimmune insulin antibody formation. And similarly, methimazole is another drug which can produce that. So this is just for information that you should be aware of this in case you see such a situation. And here you find that the insulin levels are very high. It may be in thousands you may find insulin level, and this is because of the antibodies which stimulate the insulin production, and they also have a cross reactivity with the measurement. And you are doing measurement, you may be actually looking at the antibodies which are binding to the insulin antibodies which are binding to the sites on the test device that you are using. So history is very important. The approach is to identify whether it's a true hypoglycemia, Whipple's triad is fulfilled. Then you need to evaluate further. You need to look at all these causes and see whether the patient is on any of the medications, whether there is any of these underlying conditions that can be causing hypoglycemia, and also then you see in a seemingly well individual you need to do detailed lab evaluation is necessary, whereas the sick individuals you have the underlying problem which is seen, and look for Whipple's triad being fulfilled. If that is being fulfilled, then you look at further evaluating for the hypoglycemia. If symptoms occur in the fasting state, evaluation should be done with a 72-hour fast. And even without the fast, without doing a 72-hour fast, if you have hypoglycemic symptoms, you measure the glucose is low, and then you do a battery of tests like the serum insulin, C-peptide, beta hydroxybutyrate, serum proinsulin, and urine sample for sulfonylurea screening. You can get a good idea about what the cause could be. So you need to do these tests in the presence of hypoglycemia. So that is called as the doing this test in the presence of hypoglycemia. If you are identifying hypoglycemia, do this, and then you will be able to identify the cause. And measure insulin antibodies. This need not be done during hypoglycemia. This can be done at any time. You can take a sample and measure the insulin antibodies and measure that. So fasting evaluation, typically after an overnight fast, if you measure the plasma glucose, if it's less than 55, then you can go ahead and do the test for the hypoglycemia and analyze that. If the symptoms occur after eating, that is within 5 hours of eating, you may need to do a mixed meal test, where you give the patient the mixed meal and measure the glucose levels after every 30 minutes for 5 hours. And if the glucose levels are less than 50 in any of the sample, then you can look at the other parameters and interpret that. In those who do not get hypoglycemia, then you may need to provoke a hypoglycemia by doing a 72-hour fasting test, where you keep the patient fasting. You can start overnight from the previous evening, and then you can do this. And what you need to do is that the patient can drink beverages that are calorie and caffeine free, and he should be every hour you will be checking the blood glucose and watching the blood glucose levels. If it goes below 60, then you can do it more frequently, and once it is less than 45, then you can go ahead and do the tests which I've just mentioned, that you do the tests like the insulin, C-peptide, beta hydroxybutyrate, proinsulin, and screening for sulfonylurea. And after that 1 milligram of glucagon is given, and then you measure the plasma glucose levels and see the rise that happens. That is also an important aspect that has to be done in the 72-hour fasting. So if plasma insulin levels are more than 3, they are consistent with hyperinsulinemia. And plasma C-peptide also helps in distinguishing whether it's exogenous or endogenous hyperinsulinemia. And plasma proinsulin levels also are important. So, and then important thing is to also look at I'll just take half a minute more. So it also is to look at the glycemic response to glucagon. A good glycemic response happens in people who have got insulinoma. There's a rise of more than 25 milligram of glucose levels rises after 20 to 30 minutes of giving IV glucagon. So this is how you can interpret this. I will not go into details because we don't have time, but essentially what we are saying is that a high insulin level with high C-peptide in the presence of hypoglycemia suggests endogenous hyperinsulinism, and that when it is accompanied by an increase in glucose levels with glucagon, that indicates that there is a insulinoma that needs to be localized and operated. Selective arterial calcium stimulation can be done to identify the gluconoma and treat it. And before I conclude, I'll just speak about the treatment. Treatment is acutely. You need to know that the rule of 15 for treating hypoglycemia: consume 15 grams of carbohydrates. After 15 minutes, check the blood glucose levels. If it's still less than 70, then give another 15 milligrams of carbohydrate, and repeat this until the blood glucose increases more than 70. And so this is a typical example of what constitutes 15 grams of carbohydrate, 3 spoons of sugar, or you can give a candy bar, or you can give a tablespoon of sugar. And if you're not able to, if the patient is not conscious, then you need to give IV glucose. And then IM glucagon can be used. IM or subcutaneous glucagon can also be used, because that has a role in a patient where you're not able to provide a IV access, and there it helps, but it has a transient response. And so the other important thing is that once you identify the cause, you need to treat that. Offending drugs may need to be stopped. Treat the associated diseases. If there's a non-islet cell tumor or an insulinoma, you can remove that and treat that. So these are the treatment. Autoimmune hypoglycemia does not have a definitive treatment, but over time it resolves spontaneously. Immunosuppressants may be used. This is an interesting case. We had a 60-year-old lady who had significant weight loss, huge abdominal distension, hepatomegaly, huge hepatomegaly, and she presented with recurrent hypoglycemia. Fasting C-peptides were level, low insulin, low C-peptide. As I mentioned, this is the one where there was a high IGF-2, and she was operated and she recovered completely. So this was a spindle cell tumor in the liver which was causing hypoglycemia. Thank you all for the patient hearing.